cane. Like what we do is above 100 years, if they come for this fracture, it's about 0.6 ml of bupivacaine we give intrathecally. Between 90 to 100 years, we give it about 0.8 to 1 ml. Between 80 to 90 years, we give it about 1.2 ml intrathecally. And if it's between 60 to 70, we go about, the maximum we give is about 1.8 ml in a geriatric patient. With this, invariably, majority of the times, we achieve the surgical anesthesia. And because of this dose, we produce less chemical sympathectomy. And if you have segments that are spared, we have an epidural rescue. For every segment, if it is not blocked, you just try to give, like what Dr. Silamban said yesterday, you just try to give 1.5 ml per segment that is not blocked. So this would be the option to produce at least hemodynamic disturbance. Yes. And the next question is, no, actually, what is your this thing on combined spinal epidural with a very low dose of spinal? Yeah, that's the reason why we try to go in for a very low dose. And if you have, see, I'm not against giving a general anesthesia for this patient. General anesthesia is definitely a choice for every patient group, provided we have enough infrastructure to take care of these patients in the post-operative period, and the post-operative analgesia is addressed. Because in the post-operative, the main concern is pain. So yes, if you are able to do that, like putting a continuous femoral catheter and a sciatic block and then administer an associated general anesthetic, and you have an excellent high dependency unit where they will take care of them for the possible post-operative, immediate post-operative complication, that could be a choice.
Dr. Bala, could you just say that?
Pardon me? No.
I don't think
why?
That's
No.
I really don't think that's mandatory.
No, it's not.
The patient is doing well, he can be extubated.
But as far as the literature is concerned, it's very clear. There are a lot of debates as far as GA versus regional. But one thing is very clear, enough documentation on neck of femurs. Regional anesthesia seems to have done a lot of things in advantage, in the sense the blood loss is very less of respiratory complications. These two have been definitely proved. And the third thing is decreased incidence of development of deep vein thrombosis in this patient. These three has been clearly proved. Dr. Murli.
Regarding the use of epidural in patients with vascular dysfunction, it has a curative effect on the vascular dysfunction.
Absolutely.
Even if
I was about to say that.
You will put an epidural.
I would put an epidural. We have done a study where if you monitor the doctor on the anti-medical effect.
Yes, absolutely.
You can see that there is a reversal. So this is what I call as the IABP-like effect of epidural.
Yep.
So epidural is curative. General anesthesia, if you were to give also, please put an epidural at whatever level.
Yes.
Because it has
So these are the few advantages of the regional anesthesia in patients with cardiovascular disease.
I would like to add one more thing in this. Before giving spinal epidural, I think so we should go for a femoral nerve block.
Yeah.
And then give spinal epidural, because these patients will have pain while giving
actually,
position.
yeah, the practice differ, but we are with you. Like, we do the same thing. On arrival, we give a femoral block. The moment the patient arrives, make them pain-free. Whatever time it takes to prepare, you made them pain-free on arrival. That's the best thing that you can do as an anesthesiologist in controlled circumstances. And then it also becomes easy to position the patient, whichever way you want to use it to give a neuraxial block.
Unrelated to the type of anesthesia, my question is to Dr. Ponde. Unrelated to the type of anesthesia we employ, my question is to Dr. Ponde. You said that this patient was not on beta blockers and statins. The mantra these days is statins. And if a patient is not on statin, in this patient, on what dose of statin would you start?
Oh, sure. There are some sites. We are going ahead with this case.
Okay.
We are going ahead with this case. So, Dr. Bala,
Sir.
what would you like to do with the aspirin for epidural and spinal? As you said, there's no need to stop that.
There is no need to stop aspirin.
And what would you do with ramipril?
If I decide on the neuraxial block, definitely I would stop ramipril on the day on the surgery. So, because it's supposed to accentuate the hypotension that is produced by.
So if the patient is on, the message is if the patient is on ramipril, hold at least 2 doses. That is 12 to 24 hours before, hold your ramipril. Aspirin 75 milligram doesn't make any difference at all for your central neuraxial anesthesia. Now, my issue is about monotrate. Patient is on monotrate. Stop it totally, substitute with something else. Please let me tell you, monotrate causes splanchnic venodilatation. So it's a mainly venodilator, then it is coronary arterial dilator. So it causes peripheral pooling into the splanchnic circuit and the systemic veins. So here, the chances of post-op or intra-op hypotension would increase with nitrates. There is only one caveat here. When you withdraw nitrates in a patient who is chronically taking it, there is a small, I would say very, very small chance of resurgence of angina. And that, how do you take care of that? Substitute that with nicorandil. Nicorandil is another coronary dilator. It dilates epicardial coronary arteries and the microcirculation equally well with no effect on venodilatation. It doesn't cause as much hypotension as a nitrate could cause at that dosage. So 5 milligram twice a day or 2.5 milligram twice a day would be probably a good substitute, but I would really stop nitrate completely for at least 48 hours before the surgery.
Dr. Ponde, is it that it's really advisable to start nicorandin if you decide to stop monotrate? What is your opinion on this?
That's what. Substitute with something else. If somebody is insistent, I would.
But not mandatory.
Not mandatory. Not mandatory. That's right. Not mandatory. Now we'll come to Dr. Gopal's question. What about preoperative beta blockers and statins? Now this is the ACC/AHA 2006 update on perioperative use of beta blocker therapy, and the beta blockers now are indicated in vascular surgery across the board, whether low risk, intermediate risk, high risk. In intermediate and high risk non-vascular surgeries, in intermediate and high risk patient, they are indicated. All others is a question mark, which we just don't know yet. Having said that, it becomes a difficult story then. It is easier that we follow this and is relatively working safe. These are the minor criteria. These are the major criteria. If you have more than 3 major or 1 major and 2 minor, you are better off, I say you are better off starting a beta blocker preoperatively. When and how, I will exemplify in a few of my next slides. So minor criteria, age more than 65 years, essential hypertension, current smoker, dyslipidemia, diabetes not requiring insulin. These are the minor criteria. Diabetes requiring insulin is a major criteria. ESRD, history of stroke, previous proven ischemic heart disease and a high-risk surgical procedure are major criteria. So if you have 3 major or 1 major and 2 minor, then probably you'll be better off starting beta blocker. This is easier to follow in the clinical practice than this complex table where you have to weigh risk of surgery and risk of patient simultaneously. It's very difficult to follow. So for those who are interested, this is the latest 2009 ACC/AHA focused update on the use of beta blockers. It is available online, free. So you can download it and read it properly. But the take-home messages from this update are, number 1, start beta blockers at least a week prior and titrate dose to reduce the resting heart rate between 50 and 60. That is 1. 2, bisoprolol, atenolol and metoprolol are the 3 most widely tested beta blockers. Do not use fixed high dose slow release preparation like metoprolol extended release 100 milligrams. Don't use that, because you will never be able to titrate it post-operatively when the hypotension occurs or bradycardia occurs. You will never be able to titrate it. Do not start 24 hours pre-op. So if the patient is not on beta blockers, lands up with you for emergency surgery, you have no scope of starting him on a beta blocker. It's as simple as that. Because the most important trial called POISE trial started beta blockers 24 hours pre-op in a large sustained release metoprolol 50 to 100 milligram. It increased mortality and increased post-operative stroke incidence. So it produced harm, forget the benefit. So please go through at least these 3 studies, DECREASE, POBBLE and POISE. And not to add, not the least, McGordy's meta-analysis. These 4 if you read, you'll be thorough about when to use a beta blocker, how to use a beta blocker. But the number needed to treat are, you need to treat 8 patients to avoid perioperative ischemia, 23 for perioperative MI and 32 for cardiovascular death. So number needed to treat is the magic mantra today for any trial, and the number needed to treat are far too small. So the benefit is quite large.
Dr. Ponde, in
About-
that one, just want to,
Yes.
one small thing. Like the POISE study said that if you start 24 hours prior, the mortality is more.
Yes.
And also we said that bringing down the heart rate in the perioperative
Yes.
and the intraoperative period decreases one important factor, the tachycardia, which is producing perioperative myocardial ischemia. So, do POISE study can be extrapolated in the perioperative period, or is it still worthwhile starting them on beta blocker to take the heart rate down
Within 48 hours, you mean to
within
say?
48 hours?
See, unfortunately, like every good thing has a price to pay. Beta blockers have two prices that we normally pay. That some degree of sympathetic tone that is required to stand stress is cut off by the beta blockers. And when it is cut off acutely, you will have postoperative hypotension and probably cerebral deautoregulation. That is what the POISE people have contemplated. So acutely giving a large dose of beta blocker to bring the heart rate down in the immediate preoperative period like 24 or 48 hours is not an acceptable thing. Now you'll ask me, is there any other choice? Yes, and I was going to come in my next couple of slides in that. The best drug today available is ivabradine. Ivabradine is a direct sinus nodal inhibitor. It only inhibits sinus node, has no effect on AV node, has no effect on blood pressure, no effect on bronchi, and no effect on hemodynamics. So if you want to bring down the heart rate, you just start ivabradine, 2.5 to 5 milligram twice a day, very safe, no effect whatsoever on hemodynamics, purely cuts down the heart rate. And you will be able to bring it.
How fast it works?
It works within 6 hours. So there is unfortunately, there is no a randomized trial, but there is a 3-center big study which has appeared, including around 375 patients with ivabradine, as a subgroup analysis of SHIFT trial. And in this subgroup analysis, they showed that starting ivabradine even as early as 24 hours preoperatively does help to cut down the heart rate and perioperative ischemia in cardiac patients. And could be a safe alternative to beta blockers which cannot be given immediately, and larger studies are needed to prove this point. So I think there is a choice there.
Yeah, ivabradine, is it commercially available
Absolutely.
now?
There are 3 brands. Ina Pure is one brand, Ivabrad is another brand, and Coralan is the 3rd brand. There are 3 companies making it.
And when do you suggest, for a case scenario like this, when do you decide to start on ivabradine?
Suppose the resting heart rate is 90 plus, and you have taken care of pain, you have taken care of anxiety, you have partially sedated the patient, and the rate still remains high, and the patient has background of ischemic heart disease, I would be keen.
So heart rate cutoff is 90.
Heart rate cutoff is mandatory. Now going to Dr. Gopal's question about statins. Statins are associated with reduced incidence of perioperative mortality in patients undergoing major non-cardiac vascular surgery. And besides cholesterol lowering properties, statins have anti-inflammatory effects and stabilizing properties on the plaque. Retrospective data on more than 2,800 patients suggests that they reduce mortality. A prospective study of 100 patients, atorvastatin 20 milligram